Good evening, everyone. Respected Dr. Disha Mehta Jobalia ma'am, esteemed members of IADP, and dear doctors. We warmly welcome you all back to another episode of Learn from our Master series organized by International Association for Dental Practice Excellence. Crossing 90 webinars has truly been an incredible journey for us, and we sincerely thank each one of you for the continuous support, participation, and encouragement through our webinars and social media platforms. Your positive feedback keeps us motivated to deliver quality education. For those who attending our webinar for the first time today, a brief introduction. We are the International Association for Dental Practice Excellence, a platform dedicated to empowering dental professionals. We strongly believe that quality education ensures predictable clinical outcomes across all disciplines and experience levels. Dentistry is constantly evolving and continuous learning is essential. Through our webinars and workshops, we aim to enhance clinical skills and guide every dentist in their professional journey. Now, without further delay, let us begin today's session. Today's topic of discussion is posterior indirect adhesive restorations. This session will be delivered by our esteemed speaker, Dr. Disha, MDS in Conservative Dentistry and Endodontics. To speak a few words about our speaker, Dr. Disha is an accomplished clinician and academician with extensive training under national and global mentors. She has expertise in precision dentistry, aesthetics, and evidence based clinical practice. She has been recognized with prestigious awards, including Best Dental Surgeon, and is also a published author. She is the founder of State of Art Dental Studio in Ahmedabad, focused on advanced digital dentistry. Her work emphasizes precision, aesthetics, function, and longevity, along with evidence-based techniques that elevates everyday clinical practice. Without wasting much time, I would like to invite Dr. Disha, ma'am, to take over today's session. Ma'am, welcome.
Thank you so much. Thank you so much, Doctor. Hello, everyone. I hope that after today's lecture, I'll be shifting your practice from something that's being taught to us and we'll be mechanically doing and wasting our time, energy, and earning lesser than what we should be, to be very honest. Coming to posterior indirect adhesive restorations, why these are necessary? Because the current evidence says that you cannot just give onlays and overlays where it's needed. You can also give them in your full mouth rehabilitation cases as well as your endodontically treated teeth. Yes, I'm sure many of you have this instilled thought in your mind that how can one give onlay or lithium disilicate process, which is hardly like 1.5 mm over an endodontically treated teeth. Won't the tooth fracture? Absolutely not. And this is not me that's claiming this. These are various evidence-based research articles which are PubMed index, and I'm going to share the links with you all too. Why we need to shift from traditional crowns to PIRs? Number one, you are saving the tooth. Number two, you're increasing the longevity of that tooth. So imagine you are sacrificing the most important part of the tooth when you're giving a crown, which is the enamel. Enamel is so important and so necessary, and we just blindly with our dental goggles go on and start prepping the teeth 360-degree. um, and while doing so, I am pretty sure, because I have also been in a learning curve. Before a decade, I have also, of course, hydrogenically and by mistake, but touched the adjacent teeth. When I'm say touching, I'm sure everybody is like, it's fine, it's just touching. But just imagine your aerotor, which is running at such a high speed, and it touching the adjacent. It's only going to harm the adjacent teeth. So, and most importantly, you are harassing yourself. I would really use this word, harassing yourself in trimming those interproximal areas with so much of precision. Whereas you can always save that natural contact, you can preserve, and you can just save yourself from all that mental insanity that you undergo while you're prepping the tooth 360-degree. You can save your board life as well, because imagine doing a full mouth rehabilitation, prepping 28 teeth in like what, 4 to 5 hours of time. Instead, all you need to do is just smoothen off and round off your enamel, and voila, you have the entire mouth ready for your full mouth rehabilitation. Imagine saving yourself from something that the patient also fears, that what if after root canal treatment also, doctor, the tooth will not get saved, which is a highly likely possibility, because we all know that endodontically treated teeth are prone to fractures higher than your vital teeth. Now imagine you're giving something which is preserving the natural tooth structure. In endodontically treated teeth, already you are removing a lot of tooth structure because of the caries and the excess opening, and whatever is left, you remove that also in giving your crowns. So you are answering that question very nicely to your patients and promising a life with indirect restorations. If you ask me, the last crown prep crown prep, when I say, is proper Schillenberg template crown prep that I have done is maybe 7 years ago. I have not done a single crown prep, whereas I do maybe 10 or 12 RCTs in a day, but I have not prepped a single tooth for a crown. The maximum crown prep I do is recrowning, when I'm supposed to recrown a tooth which is already crown prep. I'm just supposed to modify my crown prep. That is where I do my crown prep modification. I don't do crown preps anymore. Now, without wasting any further time, we're just going to jump into what actually are posterior indirect adhesive restorations. So when I say posterior indirect adhesive restorations are basically restorations which get chemically bonded with your enamel, and they are subject to become a unanimous thing with the tooth. Whereas when you are cementing a crown, it very much depends on the mechanical retention. Hence, those principles like 6-degree taper and parallel walls, and all of that comes into picture, because you are relying a lot on mechanical retention. Whereas when we are talking about adhesive restorations, we are relying a lot on the chemical bonding. Um, the most important part that I would want to highlight would be you can't do posterior indirects without a rubber dam, because resin is not very forgiving. Even an ounce, not even an ounce, like a drop of moisture can ruin your resin bonding a lot. So if you're doing posterior indirects without a rubber dam, you're creating a consequent failure for yourself for the future, rather than don't do it. And so I would highly suggest that they should be done under rubber dam strictly, especially the bonding appointment. So posterior indirect adhesive restorations, I am going to shift to my presentation quickly. Just a sec. Okay, so when I say posterior indirect, we always have inlays, onlays, overlays, tabletops, one-lays, crown lays. There are just so many terminologies, and I am going to just start speaking about each one of them one by one. So we know about a crown, right? Inlay is when you are covering one of the walls. So I usually use inlay when I am doing a very big classroom. For example, it's like a deep margin elevated subgingival composite restoration, and it's a huge wall that I've missed, which is a mesial or a distal wall. Then that is when I go and do my inlays. When it comes to onlays, it's because one of my cusps are compromised. Either they are not in good thickness, or they're completely gone because of caries or fracture or whatever the reason is. That is when I do an onlay. That's because I need cuspal coverage. Then comes overlay. So what is overlay? Overlay and crown lays are more or less. So overlay is something that you need as a cap. So as a partial cap. I use overlays and crown lays and tabletops for my occlusal processes in my full mouth rehabilitation cases. None of my full mouth rehabilitation cases have crowns anymore, because even if it's a bruxer, even if it's a clencher, or even if it's a habitual, like of course I make sure that the patient is done with the habit. But even with heavy biting forces, I use tabletops and crown lays and overlays. That's typically covering just my occlusal part. Now coming to the most fancy terminology that we have recently discovered. So initially they used to tell this a V-top onlay, but now they call it as a one lay. These are the processes which cover the buccal or the labial surface like a veneer, and also cover the occlusal surface like an onlay covering the cusp as well. So these are particularly the restorations that I prefer for my premolars, and if needed in anteriors as well, if the patient is undergoing full mouth through GERD, or like if the palatal portion is also worn down because of the acid reflux. This is where I use my onlays or V-top onlays. Then coming to endocrowns. Endocrowns are also really nice processes for an endodontically treated teeth. Now there are just two not various, I would say just two school of thoughts pertaining to endocrowns. One school of thought would want to not give endocrown, and I fall into that category. And one school of thought has the opinion of giving endocrowns. Now, why I don't usually give endocrowns is because I rather believe on my composite filling up the excess hole and covering up the entire dentine, and then going for a crown lay or an on lay as per the design permits. But there are people who would want to give endocrowns. So there are two different school of thoughts. You should be extremely confident that the force vectors and your internal excess are pretty fine to support the endocrown, and not let the force vectors go against your favor. So then you can go and give endocrowns. I personally fill the entire excess hole with composite, and then when I get a nice smooth surface, I'll be sharing a case also later. When I get a nice smooth surface, I then go and give my posterior indirect adhesive restoration. Coming to, these are the articles which are all PubMed index and all very recent. And if anybody's interested, just share, like text me in the inbox and I'll share these links. All these are just the like top of them. There are hundreds of them, but these are the top of them. These are PubMed index articles with evidence-based research claiming and screaming rather that we should shift from crowns to posterior indirect adhesive restorations. Coming to the basic overview as to why full crowns are not the practice anymore. See, full crowns are not always mandatory for endodontically treated teeth because crowns are now history. The endodontically treated, because like we used to give crowns because the endodontically treated teeth were believed to be brittle. Now the current evidence shows that the primary reason for fracture is not actually dehydration of dentin, but it's the loss of tooth structure. So that is what I said in the beginning, that imagine you already have a lot of tooth structure loss when you are doing the caries removal and excess opening and whatever remaining tooth structure that you have, you are removing that also in procedure for a crown prep. So imagine the actual natural tooth structure left, the integrity is lost completely, and that is why your teeth fracture most of the times. Second is the preservation of tooth structure has become the biggest determinant of the long-term survival of the tooth. See, the more enamel that you have, the more dentin that you have, and I think we are just neglecting this part of the tooth, which is the pericervical dentin. When you are preserving all this, you are automatically increasing the prognosis of the tooth. So they are conservative than conventional crowds because they avoid aggressive circumferential reduction. Point three, adhesive restorations improve biomechanical behavior because bonded restorations help reinforcing the remaining casts. They also improve the equal amount of stress distribution, and they even reduce the flexure of the weakened tooth structure. Also mimic natural tooth biomechanics. Hello? Hello? I'm sorry, did I lose you guys?
No, ma'am, you're audible.
Audible, right? Perfect, great. I'll just go back to my presentation. Just a sec, just give me a sec. Yeah. Okay. So, where was I? Yeah, it mimics the natural tooth biomechanics because that is what the foundation pillar of biomimetic dentistry is. I'm sure you guys must have come across a lot of biomimetic dentistry on Instagram, Facebook, and all other social media platforms. Excuse me. So, what does biomimetics mean actually? It's like bio and mime. So you are mimicking the biology of the tooth in every which way, via look, via function, via force distribution. So that is the foundation pillar of biomimetic dentistry. Coming to failures tend to be less catastrophic, and I fairly believe this point because I see so many, so 95% of my practice is repeat dentistry, and my heart sinks when I remove the crown and see zero tooth structure left for me to retain. Like at times, it's like a joke between my implantologist and myself, and he's like, "I bet you whatever 5,000 bucks if you can just save this tooth," and I'm just so sad. I do every goddamn thing. I use ribbon, I use pause, I do everything in my armamentarium to save that tooth. But unfortunately, at times, my implantologist wins. I just can't then help the prognosis of the tooth. Whereas if you are doing a posterior indirect recessive restoration, so for example, worst case scenario, it fails. Okay, so it has fractured, it has failed, it has come off, it has dislodged, whatever the failures you can think of, worst case scenario, it has failed. Okay, so what would be your second worry? Of course, the overheads and the patients coming back that dog is fractured and everything. But apart from that, what are your biomechanical issues that come as a problem to you? You are not facing issues like what I face, like I remove the crown and there's no tooth structure left for me to save. You easily have a lot of tooth structure to save. If there's an onlay failure, you can go and give another onlay. If you've just covered one cusp and that has failed, you can go and cover two cusps and you can give another onlay. Worst case scenario, you can always go back to your favorite crowns. Crowns are our favorite, we know that. We just blindly go mechanically do a 360-degree prep. So you can always go back to doing that. But at least you gave the patient and the tooth a 5-year, 10-year timeline. You are increasing the life. But when it comes to crowns, I have seen crown sailing in a matter of 2 years also. Because as I said, a perfectly done RCT and a crown given and the tooth has fractured. Now what can I do? I can't do anything. I have to go and place an implant. It's just how dentistry in real world works. So you can't even complain. You can't even say anything. All you need to do is just give a very stupid and bullshit thing to the patient that you already knew that the tooth was compromised. No, it was not compromised when he or she came to you. It's your tooth prep, the crown prep, that got it more compromised. So failures are quite less catastrophic with posterior and direct restorations. And the modern philosophy is completely, oh sorry, I just missed this point. Endocrowns and overlays are increasingly supported for posterior teeth. Reason being, these are modern adhesive materials which have improved bonding protocols and great predictability when it comes to lithium disilicate. And I've been hearing a lot of research happening on the zirconia industry as well, but we are yet to test that. But lithium disilicate has been a proven material for these things. Now imagine, yeah. So last point, the modern philosophy is minimally invasive and defect driven. So imagine you have like an MO. All you've got is an MO, and you try to save the tooth. You did a direct pulp capping, also putting your MT or biodentine and doing the all steps and preserving that natural the vitality of the tooth. But you had to go and do an RCT because you couldn't help it. The patient was in pain. Now imagine you have all the three casts lying with you. Your only mesial buccal or distal buccal cast has gone. So would you like go and do a 360-degree crown prep? Imagine you're wasting so much of your time. Rather, it's the modern philosophy with posterior indirect restoration is so minimal. I love my indirect restoration preps because they literally do nothing. I just go and do like a 1.5 mm to 2 mm prep if it's a functional cast, and if it's a non-functional cast, I just do a 1 mm prep. Imagine just doing a 1 mm prep and just getting done with it for like life. Imagine saving yourself from all the hassle. It's so nice, so energetic, and so amazing. Like I look forward to my PIR preps because I don't have to follow a guidebook. The tooth is my guide. The defect is my guide. The entire restoration is my guide. So I am pretty looking forward, like where will I place my margins, which cost will I involve, what will I do. So all this kicks you, all this gives you a nice adrenaline to push you to give the patient your best. And coming to the most important thing that I look forward to giving the PIRs is I don't have to break the contact. God has given such nice tight contacts and such nice that my floss also can't go inside at times. And imagine I'm breaking those contacts. Such a task, God knows. You all know, not just girl. You all made such a tough task breaking those heavy contacts. And when it comes to just giving a PIR, you are just smoothing it off. You're just making a little bit of occlusal space. You're just making sure that your processes has got good enough space to bear the functional load, and your job's done. So these are the basic fundamental advantages that I feel a crown, like an onlay or an overlay, has over a crown. And a lot of times in my workshops, my students and my participants ask me that, ma'am, how do you convince a patient who is willing to go for a metal crown and converting them to, of course, these are not cheap, so converting them to a ceramic posterior indirect adhesive restorations. So I always tell my participants that you should just give your patient two choices. Like for example, you have to undergo an intestinal surgery, for example. So would you want the surgeon to cut yourself completely open, Or would you want him or her to operate you with a laparoscopy, which just includes 3 or 4 punctures in your entire abdominal cavity? Let the patient take the fall. Let the patient take the entire blame on them. At least you are trying to give the patient the best. Whereas the patient is asking for a failure, then it's upon them. And 99% in my times, in my entire experience, clinical experience, none of my patients have said no for a PIR. When you explain, so a PIR consult is very different than a crown. How the patient gets to know that after root canal a crown is to be given? You acknowledge them, you tell them, you inform them that your root canal treated tooth is going to fracture if you don't give a crown on it. So this is a compulsory mandatory procedure that we have to perform after the root canal. That the same way you consult and you give information about a PIAR. You tell them that, listen, this my tooth structure to you have already lost and you have amazing benefit of x-rays. You can show that entire radio opaque part that you have filled up and you can tell them that this is the entire tooth structure that you have lost. Now imagine for a metal crown or a metal ceramic crown, you will remove the rest of it also. So imagine what will you be left with? So instead, you can always go for a PIAR. It's going to be a little heavy on your pocket, but it's going to save your tooth from the further expenses. Otherwise, this tooth is hardly going to have a limited life, and post that extraction implant is what awaits for you. So then you are not you're not making the patient scaring for the hills. You are just letting them know about the reality, that this is the reality, you better stick to it. And if you don't want to, it's okay, it's on you, it's not me, I gave you the options. But as I said, 99% of the times none of my patients have ever gone against my consult. Coming to the prep, a lot of times my participants ask me that, can you just teach us how to no mentor on this planet Earth can give you a guideline for a prep, because as I said, it's a defect driven prep. Whatever is your defect is your prep. So, for example, if I am doing, for example, a full mouth restoration and I have gotten completely untreated teeth. So, what is my prep there? My prep is simply rounding off my enamel, giving a 360-degree bevel, placing bud joints, and giving a morphologically driven preparation look. So the pictures that you can see on the screen are morphologically driven prep. So when I say morphologically driven, see if you can see, this is the functional cusp is having a larger prep. So functional cusp are usually 1.5 to 2 occlusal load preps, and non-functional preps are 1 occlusal preps. And what you can see on the side, this is a MOD, hence it has been. So your process is a little disilicate should be covering your entire composite. That's the rule. That's the rule in given any processes, be it your crown, be it your lithium disilicate processes, be it anything. So your restoration, be it composite, be it GI, be it whatever your amalgam, be it whatever you're doing, your final processes should be covering your restoration. That rule goes without saying. So there are rules. There are no guidelines. So just keep in your mind tomorrow when you're going for your clinical practice, just remember these 4 major rules. Number 1, you only prepare where necessary and to create space for ceramic. Again, coming back to my full mouth rehabilitation cases, everybody knows that we raise the vertical dimension, we raise the bite. So when we are raising the bite by say 3 mm, I hardly do any prep. I just smoothen it out, because 1.5 mm, 1.5 mm getting equally on both the sides. What do I need to prep? Imagine doing nothing and getting paid for it. Of course, not doing nothing. You're supposed to do your Facebook record and CR record and everything. You need to give an anterior stop and do all of that. But in terms of prep, I'm doing nothing because I'm already raising my VD by 3 to 3.5 mm, and I don't have to increase or to create space for my processes in my posteriors. So only prepare where necessary and where you have to create space for your ceramic processes. Rule number 2, a very, very, very important rule: cuspal reduction to protect from occlusal load, especially when the cusp is fractured or worn or reduced. You need to give a butt joint. You cannot leave that entire space or in the entire tooth with sharp edges or whatever, or with sharp those chamfer lines and shoulder lines and all of that. No, you have to give a nice butt joint, so much so that your processes just slides nicely over your natural tooth structure. Number 3, a very important rule indeed, for better aesthetic integration and increase of enamel bonding surface. We all know that when you do a 360-degree bevel, you're increasing the surface area for enamel, hence increasing the surface energy, hence increasing the bonding energy, and getting best bonding possible. I'm sure you all have extreme amount of doubts, like how can she bond lithium disilicate when there is dentine in between? I am not concerned with my dentine. My margins are completely placed in enamel. Say for example, if you imagine a like completely untreated tooth, do you think you have enamel loss in it? No, you have very nice 360-degree enamel trim left. So my margins should be in enamel. Rest of it is dentin. It's okay. I don't care. I'm as it is doing my selective edge and everything with my enamel. My lithium disilicate margins have to get bonded with my enamel. That goes without saying. We all know resins bond the best with enamel, and hence enamel, as more you can get, is as best for you. So sorry, getting off track from this a bit. I've had a patient who had come to me with cuspal fracture, and she was a full mouth rehabilitation case, and her two molars are fractured. And I kept telling her that, listen, you're a full mouth rehabilitation case, and you should just get done with this entirely. And she was referred to me by another patient, and hence the trust issues. She said, no, I've just come for these 2 teeth. You just please get done with it because there's been a lot of sensitivity. I'll come back to you later. So I said, okay, fine. I don't mind. You can just come back to me whenever you want. Just letting you know that you are a full mouth rehabilitation case. And currently, I'm just giving you an only for the fracture that has happened. Now, cut to, I've given her onlys and everything. And cut to 3 years later, she has now come back to me finally, eventually, for a full mouth rehabilitation. She's like, I'm just tired. Every other day, some or other tooth keeps getting fractured, and I can't wear that bite guard knife or whatever you have given to me. So let's just get done with this full mouth rehabilitation once and for all. I said, okay, fine. Mind you, it took me 1.5 hours to remove those 2 onlays. I am not kidding. This is a reality. This has happened. So imagine the amount of strength and the chemical bond that your onlay will have with your enamel. I had to literally do a prep because I couldn't get rid of it. I just couldn't get it out of that tooth. It was so nicely bonded. All other preps of mine took 2 hours, and these 2 teeth took 1.5 hours. So imagine the amount of bonding that your lithium disilicate will have with enamel. Hence, again emphasizing on having a great amount of enamel for your bonding, and hence a full bevel. Rule number 4, you should have an internally rounded shoulder. What do you mean by this? Internally rounded shoulder, about 1 to 1.2 mm. This is specifically where you have your composite restorations, or where you have any restoration for that matter. When you need to cover that restoration, exactly there you need to have an internal rounded shoulder of 1 to 1.2 mm. There is no standard prep. There's always a palatal butt joint, buccal bevel, proximal slot, occlusal block, box. All this is optional depending on your design. Coming to what guides your design is, see, the group B and C. Group B is your chamfer, and group C is your shoulder. And in your group A, there is no chamfer, no shoulder, nothing. It's a completely nicely biologically oriented preparation technique. Initially, you needed these chamfer and shoulders because your metal or metal ceramic or ceramic used to have those thick layers that need to get cemented over there. This typically gets fused with the tooth, and lithium disilicate is so gum friendly. Like even if you had a pocket, for example, if you're dealing with a subgingival class 2 composite and you have given a restoration over there covering the entire distal wall or mesial wall, get the patient back for a 1 week follow-up. You will have amazing gingiva over there. It is so nice because number one, it is polished. It comes from the lab, completely glazed and polished. It's lustrous. Hence, the gum has absolutely no problem in hugging it. So when you see after a week, and there have been times when assistant doctor also has been not been able to appreciate that where exactly ma'am put her margins, because they just flush with the tooth completely. Coming to the bonding protocol. So this is something which is, I would say, a little hassle oriented. I would agree in comparison to your GIC loading and luting and placing and cotton roll and done and removing the excess and all of that. This is little tricky because this involves a lot of steps. Hence, all these steps I would 100% urge you, not even 100, 1000% urge you to perform under a rubber dam, because only a rubber dam can ensure good bonding efficacy, and without good bonding efficacy you cannot be ensured about your PIRs to be there for a longer time. So coming to step by step, so there are two particular substrates that you're dealing with. One is your processes, the intaglio surface of your processes, and one is your abutment substrate, which is your natural tooth. So I'll just go through the PIR, the processes intaglio surface part steps first. So you have to etch the entire intaglio surface with hydrofluoric acid, Ivoclar, 3M, Bosco, all these good companies have great hydrofluoric acid. You can buy from either of them. You need to HFX for 20 seconds. When I say 20 seconds, is not an arbitrary 20 seconds. I want a dedicated person to be there for that 20-second period, because, and of course you need a timer for that, because if you like, hydrofluoric acid is a very strong acid, so if you etch it for more, you are decreasing the surface what do you call integrity of the processes. Like lithium disilicate is also a material after all. So if you like attack it with a strong acid for a longer time, you tend to have cracks. So please make sure there's a dedicated person and a dedicated timer for the same. Post that, ultrasonic cleaning in alcohol, rinse and dry, silent application, air dry, and then resin cement application is exactly how you deal with your veneers. Coming to your bonding protocol with your substrate. Now, I tend to do a lot of selective etch in my practice. I have usually done selective etches only. So my enamel is selectively etched, my dentin is self-etched. Then there's bonding agent and tack curing of the processes. The second I place my veneer cement or resin cement or Relix Duo, whatever you're working with, over my processes. I put it on my tooth structure and tack cure it. What I mean by tack cure is your lights would be having a tack cure option. It's usually 1 to 3 seconds depending on your light intensity. And that will just get the cement in a plastic stage. Once the cement is in a plastic stage, you need to remove the excess with a blade and then full light cure it for good 60 seconds. Cleaning and then adjusting with occlusion. Yes, I would like to take a minute for making you guys understand this. See, with the crown, you can check your margin fit, you can check your occlusal adjustment, and you can do all of that. With the lithium disilicate processes, you can't. You can only do your margin check. You cannot do your occlusal check, because the second the tooth bites on that onlay or overlay or crown lay, it will fracture. Because imagine something which is as thin as 1 to 1.5 mm and having it under a load of something which is harder than the bone also, like the enamel's hardness is even harder than the bone. So what is going to happen to it? It's of course going to fracture. So your occlusal checks are only going to happen after you cement your processes. This is the most important thing that you need to keep in mind when you're working with PIARs. You cannot ask the patient to कि अभी बंद करो, अभी कैसा लग रहा है, नहीं, आपको लगेगा. It will just fracture into two parts. So after you have done complete bonding and cleaning is when you need to do your occlusal adjustments. So this is the case that I was talking about. This is a case where it's heavy composite done, and when I remove the composite, the old composite, there's a lot of secondary caries that is happening. With the Dr. Alleman's 6 lessons of approach, I have, after using a caries detector dye, I have left behind a periphery of affected dentine and moved on with my composite restoration, of course, with sectional matrix and everything. I do my class 2s, I get it completely prepared, filled it up, selective edge, self edge, the entire protocol. And then I perform my morphologically driven preparation over both the teeth, and this is the trine. So all I do is trine and see whether it is having margin fit or not. That is all I do. And as you can see, this is all happening under rubber dam, so it's impossible for my patient also to buy it and check whether. So this is what I like about rubber dam also. Like, even in the haste of the mind, if you just subconsciously ask it, because that is going to happen to you, because your mind has been trained to ask the patient to bite and check for occlusal interferences during trying. And when you have already put a rubber dam, the patient can't bite it. Hence, rubber dam has various many advantages in this case. So trying has happened, and this is after cementation. You can see it has completely flushed. It's looking really natural, and I'm going back to the initial picture. I have not done anything to my enamel which was intact. I have kept it as it is. I have, of course, given a bit of occlusal reduction for my ceramic to come and cover it, but that is it. That has in fact increased my enamel width rather than losing it completely. This is what it was pre-operative, and this is what it is post-operative. In fact, this is 1 or 2 day post-operative, but still you can see the gums have healed so nicely. Despite of the fact that it has MOD in both the teeth. So this is how hugging lithium disilicate is to your gums. Coming to the end of my presentation, I would want to open this forum for questions. There are 6 questions is what I can see. Ma'am, in your workshops, do we get to do the bonding step as a part of the hands-on? Of course. The train goes off track only in bonding. So when I was also undergoing a lot of, so I keep updating and upgrading myself every year. There's a minimum of 2 conferences or 2 workshops that I've taken on an annual basis. So when I was also here a decade ago, every other mentor, I would not want to name them, but every other mentor will be teaching me how to prep. But that prep was already shown to me on YouTube tutorials. What I was going through was every wrong step in the bonding protocol. So in my workshop, I make sure, in fact, there's one entire half session dedicated to just bonding, and I urge my participants to uh, bond in front of me. So in fact, I do a one-on-one. So in my workshops, I hardly take 6 to 8 participants. Like, I don't have mental capacity to take more of them. But when they're bonding, I make them sit in front of me, and I keep asking them. It's like one-on-one vibe. Like, what will you do next? What will you do next? So that is how I do my bonding with my participants. Sorry, there are too many questions. Link. What I'll do is I will Dr. Shanu for Dr. Juneet, I'll share the links with you. You guys can post it on your Instagram story or YouTube, wherever you think. So I think that'll be better for everybody to just, go through the articles. They are lovely, lovely articles, and I would want each one of you to go through them. They are beautiful researches. Somebody is doing the job for you, so you can just take it all ready for you on the plate. Okay, ma'am, you mentioned that the prep should cover all the composites. So, what in cases where the composite restoration is more cervical proximally? Uh, uh, um, Indian population, I would like to address Indian population, only come to you when there's food lodgement happening or there is pain. In both these cases, your restoration has undergone subgingival area. So it tends to go subgingival. That is for sure, and that's the best part for lithium disilicate. Um, of course, I use cauterization. I use my Teflon. I use gingival retraction cord. I use gingival retraction paste. I do a lot of things when I'm taking the scan or taking an impression, depending on how I'm going with the record. But there are a lot of tools I need to prepare that, to like record that margin pretty well. But yes, I do record them pretty well, and they hug gums very nicely. In fact, they are better than your composite. I'll tell you why. Because your composite or GIC, when you're doing subgingival, you cannot go and polish it beyond an extent. Like, let's confirm on this that we cannot polish like a lab. Come on, like, we cannot. We just can't reach that level of polish. So imagine that frictional surface or that rough surface is inculcating a lot of plaque on your restoration, and this, in fact, will be having a smooth surface. So imagine what will stay better, your composite or your GI, or a very smooth, nice lithium disilicate. I think that should just. Can you please show the prep photo again? I will share. Just give me 5 minutes. Which bond do you use? So 5 years ago, not five, I should say 3 years ago, I was using all 3M. Now currently I'm using all Ivoclar. It just depends on my stockist, to be very honest. No, not that. I like to use one system at a time. Like, I can't have bonding agent from 3M and resin cement of Ivoclar. No, I can't do that. In fact, it's not recommended also. If you're using complete 3M, you can use complete 3M. If you're using complete Ivoclar, use complete Ivoclar. There's Shofu, there's Dentsply. I'm sure there are a lot of good standards. When I'm talking about standard, I'm talking about global standard companies. All these companies are good, but I would urge for you to take one single company. Like, yeah, just from etching to resin cement, it should have just one single company. Can it be done in large attrition? What do you mean by large attrition? As in the full teeth is treated? Yeah. Full mouth rehabilitations are fully treated teeth. Otherwise, why would you go and treat them as a full mouth? Ma'am, if there's a lot of high points, what do we do? Because reducing the opposing tooth might cause sensitivity. Please don't commit this crime. I never trim my opposing tooth. But fortunately, I've never had an issue also with clearance because I've been using a scanner, and with the scanner, when you go to the clearance check before sending it to the lab, it shows how many space you have left, and that entire picture guides me where to reduce how much. And if I've got like 2 space for a functional cost, or even 1.5 space for my functional cost and one on my non-functional, that itself is enough. For people who are not using a scanner, I would like them to invest in a leaf gauge. Your leaf gauge will guide you, like here it is 1.5 mm, here it is 1 mm. So I think a leaf gauge is hardly 300, 400 rupees. So I think you can invest in a leaf gauge. So you can do that. Please do not trim the opposing tooth. Please don't invite troubles for your own self. The patient is 100% going to come back and tell, इधर तो सब ठीक हो गया है पर अभी ऊपर शुरू हो गया है. So please, and you know that again inculcates a bad publicity that I went for this and then the doctor trimmed the opposite and now I'm feeling it. So you are playing with the loyalty of your patients. The patient is strictly going to shift, and with the current market, we know how saturated dental fraternity is. So yeah, make sure you retain all your patients. Okay, what is the difference between tabletops, overlays, and crown lays? So crown lays are more or less your supragingival crowns. Not supragingival, that's a wrong word. So if example, if you have this much tooth structure left, so this is where your crown lay will end. This I only do if my patient has a very wide smile, and molars are also visible, like the molar cusps are also visible, and I need to match the shade, and hence I go and do buckle thoda. I go down and put my margin there. That is when I give my crown lace. Tabletops are literal tabletops. It's like covering all the four cusps. It's like a table, like all four pillars, and you have a table board, a tabletop. So that's what a tabletop is. Please explain case selection. All cases are case selection. All cases. Class 2 deep subgingival composites, yes. Fractured teeth, yes. Endodontically treated teeth, yes. What do you call? Large attrition, somebody mentioned. All attrition cases, yes. So all cases are perfect indication for lithium disilicate. Provided you give good space for ceramic and you follow those 4 rules that I mentioned, you're good to go. Ma'am, please suggest some good brands. Oh, sorry, so one contraindication in your case selection would be, I just recently, in fact, I'm treating that case just now. She's a GERD patient with attrition and diastemas. So I have to basically cover all the 5 sides. I have to give labial as well as incisal as well as palatal, and diastemas I have to close them also. So that is how then it becomes a crown automatically. It is not something that I have decided on my own. It's something that the tooth is only guiding me. So again, I would want to emphasize on that fact that it's a defect driven, tooth driven design. Ma'am, please suggest some good brands of composite which bonds with dentine, and also suggest some good bonding agent brands, affordable and also costly. So if you want to invest in costly brands, I really love Cosmedent and Empress. These are the two, one of my favorite 2 brands of composite. And if you want affordable, I think Ivoclar also has come with very cheap, like in the trade expo, they came with pretty good deals. You can check with Ivoclar or 3M also, but their basic version. Like if you go and buy Tetric and Ceram 2, or you go with any other higher category, I'm sure it's going to be expensive. But even the basic composites, the starting range are good enough. which are the labs that do onlays? So I sent my work to three labs actually. One of them is Advanced Dental Lab. It's Advanced Dental Export based out of Surat. One is Dr. Mohit Suryavanshí's Precision Dental Lab in Kolhapur. It's based out of Kolhapur. And a third is the Digital Dental Lab in Chennai. But all this could happen because I have a scanner. If you don't have a scanner, then you will have to build a rapport with your lab and create a synergy where the lab can support you in such processes. Everybody is equipped with CAD/CAM these days. So ExoCAD, in which they do the designing, ExoCAD itself is equipped with designing posterior indirect adhesive restorations. It's just that your lab technician has to be a little aware of it. What is the minimum thickness of composite layer placed before giving the processes? I only do it till my denting. See, if how do I explain? If I have to do a cuspal coverage, for example, if I'm supposed to do my cuspal coverage, then I am supposed to reduce 2 mm of my buccal cusp, for example. So if it's a functional cusp and if it's a buccal cusp, and if I'm reducing it 2 mm, I am already reducing just enamel only. My enamel will stand only below there. So you are literally just replacing natural anatomy. Just keep two things in mind. Your dentin is replaced by composite and your enamel is replaced by lithium disilicate. It will just make your life simpler. Ma'am, please suggest the economic friendly curing line. I'm so sorry I don't have the answer to this because I'm very possessive about my light. I use 3M LFR. The reason is I had gone to 3M R&D center in Bangalore when they were introducing this light, and they have this entire chart as in a graph of the intensity of the curing that you're doing. So when I was curing it, so for example, this is my tooth and I'm curing it like this, I had a 100% nice graph. Okay, so good to go. But the second so all this is your happening, I've not moved at all. The second I just move my head to see the graph, that whether I'm doing okay or not, the graph drops. So that is the importance of curing intensity that you need for your bonding. So imagine not moving this and just moving my head gets me a drop in my curing intensity. What will happen if you're using a cheaper or a very, I don't want to name brands, but I know one particular one is very nicely available because it's pretty economical. But please don't invest in that. Just have one less chair, or just don't spend on unnecessary things. But composite light is something that you need to spend on. I think they're around 30-40K, but those are your worth expenses. And they run also pretty long. Like the current light that I'm using is of is 7 to 8 years old. Of course, I keep reassessing it with the technician, but it has to be a good standard light, bottom line. You cannot go wrong in that. Burrs used for preparation, ma'am. Your regular burrs, your occlusal, um, occlusal, like when you use a thick burr, football burr, or a thick burr for occlusal reduction, and the rest of it too is happening via red polishing burr through my micromotor, or one is to an engine driven. I don't use aerotor. Then I only use aerotor when I'm supposed to reduce the cuspal, the occlusal basically interference. I'm only using an aerotor and a board there. Rest everything is all about finishing it, placing a butt joint and giving a 360 bevel. All then you don't need an aerotor, or one is to an engine driven handpiece should be enough. Ma'am, please suggest something for post restoration hypersensitivity, also treatment of hypersensitivity apart from this. Firstly, you need to understand that what is causing your sensitivity. Depending on that, I can suggest you desensitizing protocols, because there are a lot of things that cause hypersensitivity. If it's a bite issue or a nutrition issue, then of course you have to go for pulmonary rehabilitation. But if it's something else, then we need to figure it out why. Because a lot of times the patients come to me and talk about post-operative sensitivity, which has never happened in my practice, because I do things carefully. Composite is a very what do you say, understated, taken for granted material, and unfortunately we all have been using it incorrectly, because we were trained to do amalgam and then switching to composite without any prior practice is very wrong. But still, it's post-op sensitivity is something a very vast topic, and can't get into it now. Ma'am, please suggest. I did mention about the economic friendly chlorine. I'm sorry, guys, I can't help you with that. Please share workshop details. I shall. I shall. Can restore the attrition 100%. 100%. I always ask my patients to go for it. In fact, I would like to show you a current full mouth that I am planning with posterior indirects. I will just show you that. Just give me yeah. So this is the case that I'm currently working on. It has completely worn out. She's a clencher. Um, and we are planning, yeah. So these are my tabletop restorations and all posteriors, upper anteriors, partial crowns, because again she has GERD, and because of that she has got palatal surface. This ceramic laminates in 1, 2, and 2 because they don't have palatal erosion. Lower anteriors, I'm planning to do injection molding via composite and extraction, of course. Those are extractions needed for wisdom teeth. So this is the current case that I'm working on. So 100% it can work on attrition. If we place Emax subgingivally, how to remove the excess cement from the subgingival area? You need to isolate it pretty well. So what I tend to do is I place my Teflon. I like submerge. I use, as I said, I use cautery, I use gingival retraction cord, I use gingival retraction paste, I use Teflon, I do all of that. And when I'm cementing it that deep, I place my Teflon nicely wound and subgingivally, and so the excess cement, the just Teflon gets it out. So just Teflon does my job. You can also use a floss, but I feel Teflon is much sturdier than a floss. Ma'am, if there are a lot of we did that reducing. We are not reducing the opposing tooth, goes without saying. In posterior inlay, what is best? Emax is zirconia. Our Indian labs have not been equipped with zirconia inlays. Plus, zirconia needs a required amount of thickness, up to my knowledge. There are people working on this, but currently I would suggest stick to Emax, which is lithium disilicate. So lithium disilicate is the material name. The company name is Emax. So that is how people tend to do it. Ma'am, which scanner do you suggest? I think these three are on top of my head. One is 3Shape Trios, which I use. Another is Prime Scan from Dentsply. I'm hearing good reviews about Itero Lumina, not the plain Itero, but Itero Lumina seems to give a lot of good reviews as of now. So just check it on your own, like get demos from people and just buy whichever you want to. In patients with bruxism, what would you suggest? Zirconia, PFM? None. None. I would suggest my posterior indirect adhesive restorations only. Ma'am, is sandblasting necessary? Of course, of course. I either do sandblasting or I do my IO clean, which is the cleaning of the processes. If you are doing Emax or lithium disilicate, hydrofluoric acid and silane and all of that does the job. Ma'am, how to reach out to you directly? Shall I just okay, I'm just going to put my details over here. Uh, for everyone to get in touch with me. I go by the name of Dr. Disha @Ivor Dental Studio on Instagram, and I am also tagging my personal number, but please do not bother me with unnecessary questions apart from this. Otherwise, a healthy discussion is always welcome, right? This is for everyone. Where on the YouTube classes? So you just so sorry. Oh my God, there are a lot of questions. Ma'am, can you share the list of armamentarium procedure precisely for reference? Armamentarium, you need if you have already invested for veneers. It's just more or less the same armamentarium that you need to use for your posterior indirect adhesive restorations also. Ma'am, in which cases do we need a proximal box or cap the cusp or just do a tabletop? Again, it depends on the kind of defect that you have. If it's a general attrition case, I rather do a tabletop. If it's just a large deep subgingival composite, then I just do an inlay with a proximal coverage. And if it is involving a cusp, I do cuspal coverage with an onlay. Ma'am, where to purchase inlay only models of facial adhesion? I don't know about this, but I'm sure the lab, if you are okay with your labs making this, you can always ask them for duplicating models. You can have a look, but again, don't take those scars as a guideline for your preps. They are not going to help you for that. Your teeth is going to guide you for that. Could you brief the class? I came late. Okay, great. You will get it on YouTube. Where on YouTube is the class available? Name of the channel I don't know. Please answer here. Ma'am, in the case the tooth goes for a VRCT, is it able to remove the processes easily? No, no. So as I said, I had a hard time removing my own onlays. So if the tooth goes for a VRCT, I okay. No, no, no. So rather treat your VRCT with a class as a class one opening. Like you can just go with the class one access opening with your onlay there, and then when you are needed for final restoration, you can remove it. But it's a tricky one. I have always been scared of removing onlays. They are the worst things to remove. Ma'am, large nutrition cases, do we need to go for RCT to why? Guys, again, it's a really huge topic, full mouth rehabilitation, but just giving you a brief light. I see a lot of dentists performing root canal treatments in full mouth rehabilitation cases. Why? If so, there's a thing called tertiary dentine. There's a thing called secondary dentine. There's a thing called calcification. There's a thing called restoring the VD. All these things tend you to not go deeper. Why do you want to make your teeth prone to fractures? 98% of the cases that I have treated as full mouth rehab, not just me, all the good mentors across the globe who are actually doing full mouth rehabilitations via ethical method, do not perform an RCT. It's ethically wrong. You're committing a crime. Please don't do RCTs in full mouth rehabilitation cases. They are not needed. You're in fact increasing the height. Why do you want to go and make excess holes and devitalize the tooth? Please don't do that. Ma'am, do you use blaster or aqua care or something like that? Okay, guys, there are two different things. Your sand blaster is to be used for your intaglio surface of the processes, and aqua care, which is the air abrasion device, is used for your abutment teeth. Why did I not emphasize on aqua care? Because it's an expensive investment and it's usually used to get rid of your biofilm. But when I'm doing proper oral profile access and doing good HF and there's nice rubber dam isolation polishing and all that happened, my biofilm is not my concern. If you're doing aquacare air abrasion, great. You're just increasing the bonding efficiency by maybe 10%, but you are not doing something wrong if you're not using it. Ma'am, while doing composite filling, do you etch the dental surface before placing onlay? I do self etching. Can the restorations be done for abrasion and abfraction? Yes, yes. For abfraction and abrasion, I tend to fill my. So again, guys, dentine composite enamel lithium disilicate. I think that answers your question. Can we do these for patient with tobacco habit and collagen? 100% yes. Ma'am, please take hypersensitive examine when possible. Sure, I will. How much can we charge? So I charge 12 to 15K for processes. You can charge whatever your standard market local rates are in your city. Ma'am, in an MOD type case is RC, that is RC treated. What would you suggest? An MOD only. If you have all the good cuts there and just MO and DO boxes, a really nice MOD inlay will do the job. What to do if you have given inlay? If you given inlay on vital tooth and it starts hurting after that, how will you be able to remove it? I'm not sure how to answer this. Why will the tooth start hurting if you have gotten rid? See, guys, you have to make sure of your biological factors being entertained first. Like your biological risk and the factors have to be assessed and entertained first. Only then your mechanical factors come into play. So if there is caries or if there is something which can cause the tooth hurting after my procedure, I would rather treat it first and then go for my prosthetic. Right? I think I've answered all of them. On you, Dr. Juna. I
Yes,
think we are
doctor.
done.
Okay, thank you
Yeah.
so much, ma'am. Thanks for sharing your valuable knowledge and expertise in managing posterior indirect adhesive restorations. And I'm sure all of us are taking back insightful clinical tips and practical techniques that we can immediately implement in our practice. And thanks to all the doctors for your patient listening and
Somebody has
active
said,
participation. And hello?
yeah.
Yeah,
I'm
we
glad,
too.
Dr. Juna, your platform. I think they were like what 130 participants.
Yeah,
I'm glad at
almost
least like
140, above 145 was there.
how nice. I'm
Yeah.
glad I could be of some insightful help to them, and I'm hoping to see a shift from traditional crowns to posterior indirect aggressive restorations. Yes, finger crossed.
Yeah, also, we encourage everyone to check out and follow ma'am's Instagram page to appreciate her clinical works and all. And to stay updated on our upcoming webinars and workshop, please do visit our website www.iadp.org or follow us on Instagram and Facebook. If you have missed any of our previous webinars, do check out our YouTube channel and don't forget to subscribe. Okay, ma'am. Thank you so much once
Thank
again
you so
and have a
much.
great
Thank
night.
you.
Good night, all.
You too. Good night,
Good night, ma'am.
everybody.